In this lecture, we will discuss Brugada syndrome, including its clinical significance, 3 different patterns, and characteristic EKG features. Subtle differences in QRS complex ST segment or T-wave morphologies generally represent benign variations. However, in some cases, these changes may be diagnostic clues to identify rare inherited disorders that are associated with an increased risk of sudden cardiac death. These inherited disorders can have unique underlying mechanisms and presentations, but there are a few characteristics that they share. These characteristics include 1, an increased risk of sudden cardiac death, as we mentioned. The second is they are the result of functional mutations in ion channels, ion channel accessory proteins, or myocardial structural genes. The third is that they are mostly appear in the absence of overt structural heart disease, okay? And the fourth is that they have characteristic EKG patterns, and it is the characteristic EKG patterns that help differentiate these inherited arrhythmia disorders, okay? Because we'll see all of them tend to have those first 3 things, okay? They all have an increased risk of sudden cardiac death, they have functional mutations, and the absence of overt structural heart disease. So it's this one here, the EKG pattern, that will help differentiate them. Now in this lecture, we're going to look at Brugada syndrome. So the Brugada pattern was first reported in 1953. However, it did not become recognized as a clinical syndrome until this EKG pattern was associated with sudden cardiac death in 1992. It is now believed to account for as many as 20% of all sudden cardiac deaths in adults with structurally normal hearts. The disease is believed to be inherited in an autosomal dominant fashion, meaning that it only takes 1 gene mutation in order to develop this disorder. It is most commonly associated with the mutation of the SCN5A gene, which encodes for a sodium channel. This mutation reduces the flow of sodium ions into the cells. In addition, men appear to be more affected, about 10 times more often than women, and they have a higher risk of developing malignant ventricular arrhythmias. The average age of presentation is around 40 years, with the patients being asymptomatic before the age of 20. The incidence of symptomatic arrhythmia in children and adolescents is quite rare, although there have been some reports in infants. Now, the resting EKG in these patients demonstrates a coved or saddleback type ST segment elevation in the right precordial leads V1 through V3. This EKG pattern is dynamic and often concealed. Therefore, it makes sense why the diagnosis can be missed at times. These EKG changes, along with the arrhythmias and deaths, are more common during rest, sleep, fever, in situations that really increase the vagal tone. Physical exertion does not actually seem to provoke arrhythmias, which helps to distinguish Brugada syndrome from other channelopathies, such as long QT syndrome and arrhythmogenic right ventricular dysplasia. Oftentimes, the use of sodium channel blocking agents or vagotonic agents like flecainide or beta blockers can unmask these EKG features. In addition, the pattern may be unmasked if the patient is febrile, has high serum calcium levels, or has taken cocaine. Alright, so let's take a closer look at these EKG features. So first off, you should know that the Brugada pattern is the hallmark, which is a pattern of pseudo right bundle branch block and persistent ST elevation in leads V1 through V3, okay? So what I'm going to show you here is this this Brugada pattern, which is that hallmark pattern, and it's a pseudo right bundle branch block, meaning that it appears like there might be a right bundle branch block, but in fact it's not. It just looks like it, okay? Same thing when we talk about a pseudo-infarction pattern, okay? It looks like there's an infarction present, but in fact that's not, okay? So let's look at what that is. So we're looking at the QRS complex. So if you look here at type 1 that we'll look at shortly, where again we're looking at V1 through V3 as we look at all these types. And remember, with right bundle branch block, you can see the RSR prime, or those rabbit ears in the right precordial lead. So imagine that you have this R wave, this S wave, and then this big R prime here, okay, right at that J point, okay? So it kind of looks like there's a right bundle branch block maybe, okay, but that's more of a pseudo right bundle branch block pattern. And we also have persistent ST elevation that we'll see in these leads, okay? So notice, remember, we take our PR segment, okay? So let's use our PR segment at the end of our P wave and use it as our baseline. And notice that we have elevation here, okay? And we'll see that throughout that there is ST elevation persistent throughout, as well as the pseudo right bundle branch block pattern that you'll see in each of these types, okay? So that's what we call the Brugada pattern, okay? And it's the hallmark of this syndrome. Now, since the original description of Brugada syndrome in 1992, there have been three main associated patterns described. There's the type 1, type 2, and type 3. And we're going to look at each of these patterns now. So the first type, or first pattern is type 1, which is the most common of the three types. Type 1 has a prominent high takeoff J-point elevation with a coved type ST segment elevation with an amplitude that's greater than or equal to 2 millimeters, leading to an inverted T wave, okay? So let me just erase this so we can see what's going on. So now we're going to look at the three types. Again, I want you to notice that we're looking at V1 through V3, those right precordial leads, and now we're looking at type 1 first, okay? And you can follow here on the chart, and we're saying that in type 1, we have a J-wave amplitude that's going to be greater than or equal to 2 millimeters, and you'll notice that it's the same in all these types. Okay, so notice here labeled in A that I did here, it's at least 2 millimeters or 2 small boxes high. Okay, so notice you can see that here it's greater than 2 millimeters. We see a coved or ST wave. So notice here in B, which is this point here, you can see that it's actually coved in its morphology or configuration. Okay. You can also see the descending terminal ST elevation. Okay, so the ST segment is elevated, but again, the terminal portion is still elevated here. Okay, and it's descending. And we have a negative T wave or T wave inversion in this case. Okay, so this D here is our negative T wave or T wave inversion that we see. So that's type 1. This is the most common of the three types. Okay, so it's important to know this one of the three. Now it's important not to confuse this pattern with right bundle branch block because the consequences can be life-threatening, right? This one, remember, some people can have right bundle branch block and it may not be even pathological, okay, or even harmful to the patient. However, if you see this sort of pattern, the pseudo right bundle branch block pattern, this could actually be life-threatening and lead to ventricular arrhythmias, okay? Now, another thing to be aware of is that type 1 pattern has the strongest correlation with the risk of ventricular arrhythmias and cardiac arrest, okay? That's why I say if you're going to know one of the three, make sure you know this one, type 1. So now to type 2 pattern. Now this pattern has a high takeoff point of the J point elevation that's greater than or equal to 2 millimeters, just like we saw in type 1. But this time we have terminal ST segment that remains at least 1 millimeter above the baseline and leads to a positive or biphasic T wave. There is a saddleback ST-T configuration, which is why you may hear it referred to as a saddleback configuration, okay? So if you look here, now we're looking at type 2, and you can follow along. So notice again, the J point elevation is still the same as in type 1. Okay, so here we have type 2, here's point A, you can see that it's still elevated here, okay? And then we see that there's that saddleback ST-T configuration, okay? So notice how it dips down, okay? So I want you to see how this is dipping down. So you have the J point comes up and it dips like that. So that saddleback ST-T configuration, the terminal ST elevation will be above 1 millimeter or 1 small box, and you can see that here. Notice that's at least 1 millimeter, and that's something that will differentiate it from type 3. Okay, type 3 we'll see it's less than 1 millimeter, so this is important to differentiate it. And then we'll have either a positive or biphasic T wave at the end. Okay, so the positive T wave, which you can see here, is the one in this case. Okay, it can also be biphasic. All right, so hopefully that makes sense, and that's the type 2. Now in the third pattern, that is type 3, there's ST elevation of less than 1 millimeter in the precordial leads with either a coved or saddleback type morphology or even both. And the T wave is typically positive in this pattern, okay? And again, you also have that J point elevation that is at least 2 millimeters, as you see here in A, so this is type 3. So all of them have this A, okay? All of them have a J point elevation at least 2 millimeters. Then in this second part, B, we can see the saddleback configuration, but it can also have that coved configuration where it just slopes down like that, okay, like a cove. That's why it's named that. And the terminal ST elevation will be less than 1 millimeter, which is this point here, okay? And this one differentiates it from type 2. Remember, in type 2, it was greater than or equal to 1 millimeter. And then here, we can have a positive T wave, okay, at the end. So this is our positive T wave that we see there in letter D, okay? Now it's important to remember that Brugada pattern is often dynamic, as we mentioned earlier. In other words, all three patterns can be observed in a single individual or even be completely concealed, wherein we won't see them at all. In addition, if you see type 2 and type 3 Brugada patterns, you can only make the diagnosis of Brugada syndrome if it converts to type 1 pattern upon administering class 1 antiarrhythmic medications. Now, just a few last points here. If you make the diagnosis of Brugada syndrome, you should also consider checking the family members and asking them to be screened. Furthermore, alcohol consumption should be avoided as it is thought to be pro-arrhythmic in these patients. Implantable cardioverter defibrillators, or ICDs, and or quinidine, which is a class 1 antiarrhythmic agent, may be helpful in symptomatic patients to prevent sudden cardiac death and reduce the incidence of ventricular arrhythmias, respectively. So let's review what we discussed before we end here. So remember, Brugada syndrome has the hallmark Brugada pattern, okay, plus sudden cardiac death. You need that risk there, okay? We mentioned what inherited arrhythmia disorders tend to have, okay? These four common things is the EKG pattern, that Brugada pattern that differentiated. Remember, this is an autosomal dominant, meaning that you only need one mutation to pass it along, and that's why we want to screen for family members if we see one that has it. It's a sodium channelopathy, and it's this SCN5A gene mutation. Remember, it's more common in males, and they're at greater risk for these malignant ventricular arrhythmias. Now, we mentioned three different types. Okay, and type 1 was the most common one, all right, and we showed these different patterns here. We're not going to go through them all again, but remember, type 1 is the main one that I want you. It's the most common one, the most lethal one. And remember, if you see types 2 and 3, you can only make the diagnosis of Brugada syndrome if it converts to type 1 pattern upon administering that class 1 antiarrhythmic medication like quinidine or something, okay? Remember, this is a dynamic pattern, and it may appear at rest, at sleep, when you have a greater vagal tone, patients with fever, if you give sodium channel blockers or vagotonic agents, okay? So again, remember, there are three different types, and type 1 is that most common. You want that. We'll go over that one here. Remember, looking at the right precordial leads, J-point elevation of at least 2 millimeters, coved STT configuration, descending terminal ST elevation, and a negative T wave, okay? So again, an important syndrome to be aware of. It's becoming more common as we're able to recognize it more often, okay, and being better to detect this. Well, that's the end of this lecture. We discussed Brugada syndrome, including its clinical significance, three different patterns, and characteristic EKG features. I hope you learned something.